Um, Hi, everyone. Erin Foley here, co-president of NADF, and you're our moderator for what has been a wonderful inaugural Adrenal Health Conference. I am pleased to welcome our NADF board member, Dr. Liz Regan, who is an academic physician researcher with National Jewish Health and is the principal investigator on our MyAI Adrenal Insufficiency Registry, which has been mentioned a few times in the past 2 days. So Liz is going to tell us all about the MyAI registry, and she's also going to talk with us about some emerging trends and treatment strategies as we look forward for the future of navigating our adrenal disease. With that, I'll hand it over to Liz.
Thanks very much, Erin. I am so grateful for the opportunity to talk to the group because this is a passionate area for me. And one of the things that I'm boggled by, it's been 70 years since people with adrenal insufficiency were freed from a death sentence. This is not a good disease to have. And I'm really grateful for that. I'm grateful for all the researchers that have produced cortisone, cortisol, and allowed us to keep on living. The problem is that our lives aren't perfect, and so I feel like I have a mission that I want to share with you and talk about how to try to make our world even better. We're not dying, but for some people, we're maybe not living yet, and that's a problem. So I also have to share my huge excitement that we've done an awful lot in the last few years, but there's a lot more that we can do. And I have huge hope that we are going to continue to move forward. I'm happy to say that we have a great team that I work with at National Jewish. We meet weekly and we are trying to strategize and move forward with a research agenda that will hopefully get us where we all need and want to go. I'm very open to having other people join us. So if you hear this talk and you say, gosh, I want to be involved, please feel free to email me. We all have different roles that we want to play, and I'm happy to talk with people who feel like they might want to be involved in what we're doing. So good to just quickly, this is a small thing. AI used to be our acronym, and then artificial intelligence stole it. So we're looking for a new acronym, and I think I'm going to propose to use in today's talk and maybe in the future ACI for adrenal cortical insufficiency, or maybe adrenal cortisol insufficiency. But just that's an FYI. So a little bit on my three hats, and I express my gratitude to my long-suffering golden retriever who was willing to be a photo subject to illustrate my three hats. I am a long-standing old physician. It's been almost 50 years since I got into medicine, started medical school, and I've had a wonderful career. I love medicine, and I have huge empathy for my physician colleagues. It's a difficult job. And if I sound critical in some of my comments, I also really understand how difficult it is. So I practiced for 20 years as an orthopedic surgeon. Again, loved my job. Developed an autoimmune arthritis that truncated my career. So I went back to school, did a Ph.D. in clinical research, and now have worked for the past 20 years in what would be described as chronic disease epidemiology. I study lung disease, musculoskeletal disease, aging, and adrenal insufficiency is a chronic disease, so it's fair game for me. The final hat is that I am a person with adrenal insufficiency. We got another acronym, PWAI, love it. This is, of course, an important driver, not only for me, but for my two daughters, because if one person has adrenal insufficiency, their genetic relations have an increased risk. So it's important to me for many reasons. My experiences as a patient or a person is really where I'd like to be, not a patient, have not been optimal. I can very comfortably say I have shared much of the misery that I hear from other people about their experiences. Very disappointing to me as a physician. I didn't get any special treatment, and I have gradually figured it out, found good doctors, and it's working, but it's been 10 years. So let me start moving into what I'm supposed to be talking about, which is our research. Um, myself, I live reasonably well with adrenal insufficiency. And so in this talk, I'm really not going to spend time on my experiences. I want to talk about research because this is where I think I can make a difference in what's important. Um, we can use research to advance our world. And that's something that I think I and hopefully others can uniquely bring to the community. I'm not going to say that there hasn't been a lot of research. There's a ton of published research on adrenal disease and even adrenal insufficiency. The problem is that we still have problems in our care as individual human beings with the disease. Most of the work that's been done, and it's really good work, has been around the biochemistry of cortisol and the secretion patterns, the action of the hormone, all really important stuff. But there is a gap, and that a knowledge gap is the juicy stuff for research. We look for knowledge gaps because that's where we want to research. The knowledge gaps for our world is that we don't know much about how this disease specifically and in detail affects a human being. There's been very little work done in that area. So that gets called patient-centered research. It's a real thing, and there's real funding to do that. And our registry was actually designed because it leads us into patient-centered research. It's been very important. And in order to make a change in the clinical practices in endocrinology, we have to produce research, high quality research, and publish that research in order to effect a change. So it's a very different area than what's been done in the past. The endocrine community is gradually learning that maybe there are patients behind this screen, and I think we're making progress, but we've got a long way to go. The two things that I see that are really important beyond changing things is that as we think about research, and I want us to think about it as a community, that we need to have a vision for the future. It's going to help us stay on a task. So I'm going to lay out some of what I've been thinking about and hope that over time we will continue to engage and discuss that as a community. And the key thing that I want to say about the registry is that we started it and it has had impacts on our world already. And I'll try to celebrate those impacts with you and talk about not only what they are, but where they lead us. So back in 2017 was my first trip to the Endocrine Society meeting, and I went in costume, so to speak. I did not say, "Hey, I'm an adrenal insufficiency patient. I want to know what's going on." I went as a physician and said, "Yo, I'm interested in why there's no research in this area. It seems like an interesting area," and chatted with a lot of people. Heard some consistent things. So one of them was, "Oh, it's so rare that nobody can study it. It's yeah, there aren't enough patients." That was one. No funding. Yeah, well, that's life. It's too complicated and there's too much variability between patients. Well, I got to tell you, that's medicine. All disease is complicated, and all presentations of medicine are variable. And so that's just life. And as a researcher in this area, I'm going to just say, hey guys, let's get going. Let's stop being stuck here. Let's move forward. The one that shocks me though, now especially because I'm still hearing it even at this year's endocrine meeting, oh, the current treatments are fine. Patients are doing great. My patients are all doing well. Now, that is true for some people, but it's not true for everybody. And our data suggests that it's not true for a lot of our community. So let me tell you a little bit about the registry. And some of you may know about it, so I'm going to be brief. This was started in 2019. It was kind of a shoestring effort to start with. We had a few people sign up. The NADF has been hugely important for this effort. First of all, just sponsoring it, and then ultimately providing funding. It would not be in existence without that support. And I know that that support ultimately comes from our community and their support of the NADF. So, ongoing big thank you to all players in terms of that funding support. We have more than 1,000 people in the registry, and that is stellar. It's structured as a research cohort, and that's a specific detail. It's valuable to us, but the reasons from it are a little bit convoluted. At the moment, I am holding active research off. I've closed it down because I feel that we need to move it to a new storage site, and I'm hoping to have that back up and working in the next month. And the basic registry, if you have not encountered it before, it is a web-based enrollment. It does involve a research consent where you say, I understand I'm going to be a research participant. The research involves collecting data from you about your experiences. And then we do follow-up surveys every 6 months, basically to see how are things going. And candidly, are you still alive or dead? Have you had an adrenal crisis? Has something awful happened to you? Are you doing okay? Because we don't know how people are doing with this disease. And collecting this information actually is really important. We do have some optional projects that go along with the registry. It's purely a matter if you're interested, you can sign up. We are collecting DNA from people, a buccal swab of your mouth. And then we also are doing a saliva collection for cortisone levels at 3 different time points. The most important thing I want to highlight, though, on this slide is we need medical records if you join the registry. And I'll talk about that a little bit more in a minute. Who's in or out? This, for some reason, our community is funny about this. Um, it, and I understand why. But an adrenal insufficient patient, for the purposes of the registry, is somebody who has a physician diagnosis of adrenal insufficiency and is taking chronic hormone replacement. That does exclude some people, and I didn't want to let them go. So we have a second group, which is called our at-risk group, and that can encompass anybody who has a range of about 7 or 8 different risk factors for developing adrenal insufficiency, including family members and people with ambiguous diagnoses and people who maybe have stopped medication because they're doing fine, but maybe still are at risk. And then finally, we have normal controls in the group. So we do a bunch of surveys and try to collect information on how people are doing. And what we know so far is that our cohort is predominantly female, white, well-educated, and affluent. Now, in the epidemiology world, that's not good. That is a skewed population unless it reflects the truth. And my fear is that it does reflect some truth, probably not completely. But in order to be diagnosed, people typically report 7 years on average. And a lot of people are diagnosed in crisis, which means they're a diagnostic failure. And so if you are not affluent and well educated and persistent, you may not get diagnosed and you may die. That's not good. Um, we can't answer that question now. We're going to need other sources to try to tease that out. But for the moment, the registry demographics are what they are, and we're studying the people, and we're going to continue to report on what we find out. We do need your medical records because the endocrinology community does not want to accept the results of the adrenal registry unless we have reasonable evidence that people actually have the disease. I get it, and I need your help to get there with your medical records. We will continue to pester you for those records. I've been thrilled with the distribution of people. Unlike many previous studies that are narrow within a small community or population or a small academic center, we have people from across the entire United States in proportion to state populations. This is very good. Some of the initial findings are that maybe about 75% of our participants aren't doing great. Now, that means 25% of people say when they tell us about their lives, I'm fine. This does not matter. I'm living my life. I'm doing fine. I don't have any complaints. I'm thrilled to pieces for those people. And so I'm not going to worry about them, but I am concerned about the other group that's not doing well because I think that's an important issue. Um, what people report is that the treatment that they're getting does not seem to manage their symptoms so that they can live a normal life. And that's reflected in what are called quality of life inventories. People with adrenal insufficiency have significantly, dramatically reduced scores on those kinds of surveys. Unfortunately, existing research lags far behind what's being done in other diseases. I work in the pulmonary world, vastly different. You know, not a judgment, just a reality. We need to push the quality of the research and the amount of research up in order to get our questions answered and move forward. Our current guidelines from 2016, the Bornstein paper, outlines treatment recommendations for primary adrenal insufficiency, and that's kind of extended across the whole of the treatment spectrum for secondary and tertiary with some variations. Those guidelines are based on inadequate data and they're very outdated. The guideline writers recognize that and they say a lot of people with these guidelines are still symptomatic. But they also say they will not change the guidelines without significant randomized good quality research studies. And so that's the driver for what we need to do with research. Down at the bottom, the last bullet, few providers understand adrenal insufficiency and many have little or no experience caring for people with adrenal insufficiency. This is a crux problem. I am going to strenuously argue that we can do better. Medicine has advanced hugely. There's a lot of new techniques. There's a lot of ways we can find out better answers to things like prediction of who's going to get disease, who's going to be sicker, who's going to respond to treatments. There are ways to answer many questions, and we're not using those tools yet, in part because we haven't got the research structures in place. And I'll talk more about how to get there. Right now, many of you may be aware that there are problems with the current recommended treatment, which basically is twice a day oral hydrocortisone. And unfortunately, oral cortisone only lasts for a short time. It has a 90-minute, what's called half-life in the blood, and probably is reflected in symptoms. If you've seen Dr. Peter Hindmarsh's book or read any of his paper, he has beautifully outlined this in published work. On the left graph, you can see a normal 24-hour graph of boys and girls with cortisol production. And you can see that it starts at 8 o'clock in the morning with a peak, and it drops down to a low point around midnight, and then starts to come up overnight to that same peak, and it cycles over day after day. On the right-hand side, you see what cortisol levels look like when you dose somebody 3 times a day. And what you see is that there are peaks and valleys. Peaks are potentially not good, too much, and valleys are times when there's nothing going for your cortisol, and this may be a problem. So this is known, this is published, but we haven't changed the treatment. And so the current thinking in endocrinology that we're all told, particularly as we start on this journey, is that the treatment guidelines recommend twice-a-day treatments, and then you find out, whoa, this maybe isn't working well for me. It's based on historical teaching rather than data. What can I say? That's the truth. Unfortunately, it's really hard to move forward, in part because patients, us, have a lot of trouble characterizing their symptoms and reporting them. And so some of our work is targeted at understanding symptoms. I'll talk more about that in a little bit. The truth is that the current treatment, twice-a-day hydrocortisone, would never be FDA approved because there's no evidence that's been presented so far that it actually controls symptoms over the course of a day or even prevents bad outcomes. We know that a lot of people are still having adrenal crises and dying. So we don't have evidence, even with the existing guidelines, that it works, but it's there, and that's what we're stuck with. So where do we go? There are alternative treatment strategies that have been published. I suspect most of you know that there are some modified release hydrocortisone preparations in Europe that are not available in the US. And there are ways to try to mimic that, which we're going to talk about. And then there's also an increasing number of people trying and physicians publishing on the use of a subcutaneous continuous cortisol pump technology, which I think both of those are interesting. We have a problem, though, and that's the Goldilocks dilemma: too high, too low, just right. Too much of a good thing is a bad thing. And the example that is widely used and talked about by endocrinologists is too much will be very dangerous for you. And so we cannot increase your dose. You need to stay at this low dose, even if you feel crummy. There's a foundation there. We know well that Cushing's disease is a devastating illness that is related to too much cortisol being secreted. This graph is not data. This is created because I want to illustrate a point. The levels that have been reported, and it's difficult to get this data even from published information, but basically the evidence suggests that either you have sustained high levels of cortisol or you have high levels of cortisol during this midnight low point that are problematic and cause significant disease and side effects. For us as adrenal insufficiency people, we have a different problem. We need to match what should be there, and at the same time, figuring out how much is right is very difficult because we have no biomarkers to say what's good or bad. There's not consensus that measuring cortisol, which is being shown here, is predictive. I'm not sure that that's true, but that's the current accepted wisdom. So we do not find that when we go in to see our endocrinologists, they're saying, oh gosh, let's check your blank level. Diabetes has hemoglobin A1C, blood sugar, lots of other metrics for a variety of diseases. We don't have that. We need to develop that, and we have to do that with research. Other challenges, it's a rare disease. It's tough to track. There's complex physiology. There's no good endpoints, no biomarkers, and not much going on. Case definitions are somewhat flawed, and the previous publications that we'd like to stand on top of, yeah, they're kind of shaky. So it's not an easy area to move into. And then kind of as an aside, but closely related is, what about patient care? So we can talk about research, but ultimately the story needs to be about patient care. And how do we decide what the best treatment options are for adrenal insufficiency? And one of the things that I really want to mention as we get into talking about the research is that it's probably not going to be one size fits all. Um, People vary in terms of the severity of the illness and their personal preferences. Everybody may not choose to have a high-tech pump or a complex oral dosing regimen. Some people may be perfectly happy to feel kind of low and slow, middle of the day, or have an increased risk of developing an adrenal crisis if they're walking on a marginal line. There's room for preference. But before we get to preferences, we need to have better data for us to make informed decisions with our patient, with our physicians. And we need to tell our physicians, unfortunately, or for better, how we should be monitored. They're not going to come to us and tell us this is how we're going to do it. And we probably don't even want that if they don't understand the disease. We need to take a forward step, ultimately look at the data and advocate for what's going to be best for our care. So that's an aside. And that means that as we go forward with our research agenda, I want us to keep in the back of our minds that we need to partner with the clinicians and come up with the best solution for all of us. We also need good science. I'm not going to, this is my nerdy self. I love talking about the science, but I'm not going to bore you with it. But I want to highlight the last two bullets here: publications and scientific engagement and comparative effectiveness studies. These are the two things that I think are absolutely key for us to move forward with in the future. If we've already had some publications, and I'll show you those in just a minute, they are changing the perception of our world. They are changing how clinicians think about adrenal insufficiency, and they are changing attitudes about whether or not patient-centered research can or should be on the table. That getting publications out is incredibly important, and we need to keep working on it. The other thing are comparative effectiveness studies. We need to get the rigorous data to bring back to the guideline writers and to the endocrine community and say, this is the best data that we can come up with for right now. We'll continue to try to improve it and get more and better data, but this is a foundation that you can work from to change treatments and improve my care. I'm going to flash past this one. I do want to make it clear that not all studies are good. And the one thing that I really worry about is this notion that there's a top level that, and this does get bandied about. Hydrocortisone dosing higher than 25 milligrams a day is associated with worse outcomes. There have been some studies that make that association, but they do not adjust for the fact that people vary in terms of their metabolism and absorption. So if somebody is a poor absorber, they may well need more than 25 milligrams a day for an oral dose. And so this notion that there's a hard stop needs to be addressed, probably um, in terms of changing practice. I don't know when and how we want to do that, but this is a concern for me. Okay, what have we learned from the AI registry? Well, we've gotten direct analysis, but the other big thing is it's moved us forward into this world of patient-centered research and working with PCORI. This is now moving, I'm going to signpost. I'm changing slightly topics. We've done some work in the past, and I want to summarize what we've done before we move to what the future might be. So back in 2015, the NADF did a survey of members in partnership with ARDA, the Autoimmune Research Registry, I believe is what that acronym is. I analyzed that data and published it because there'd been nothing published about adrenal insufficiency in the US. It all was out of Europe. This paper focused on the diagnostic problems where about half of people were not diagnosed properly. They had problems. And there were a significant number of people who were told they were excessively concerned about their care. It was kind of an interesting survey. Since that time, I've become a lot more, I guess, sophisticated about what we're doing, and I'm trying to move. That was a pretty early and limited report on what was going on based on an analysis. And now what I'm trying to do is really bring our research up to a level that's commensurate with the rest of the world. And so I'm going to show you about some projects that we have done or are doing. And a quick summary, we're looking at symptoms, we're looking at experience with emergency injections, we've looked at levels of cortisol and cortisone in saliva and blood, we have our DNA collection that's ongoing, and we've got my treasured PCORI submission. And finally, I think a really important paper coming out on defining adrenal crisis for our physician and EMS colleagues. So the first one, this is chewy. I'm not going to go into detail on what this is showing, but basically a colleague of mine, Greg Kinney at the Colorado School of Public Health, looked at the symptom data that we collected from people when they enrolled in the registry. There were 40 different symptoms that people were offered the opportunity to identify as being symptoms that they experienced before diagnosis. Greg took that information and using a methodology called latent class analysis to data reduce those down, found that they clumped into 6 different groups, and they predicted the risk of being diagnosed or being not diagnosed, basically. So the metric was diagnosed in crisis, which means that they missed the diagnosis and you ended up in the ER, bad doctor. This is very interesting. We presented it at Endocrine this July in San Francisco, had a lot of interest in the poster, and I think it's going to be a nice publication. Last year, we had a project with my group with some of our students. They analyzed data from the NADF survey about injections, and we found that 40% of people who needed to have an emergency injection were unable to accomplish that injection. And the reason was they were too sick. And so one of the foundations of what the endocrine world has been believing is that they can just give their patients an injection kit and crises will be taken care of. That's not true. We got problems, folks. And we definitely need auto injectors, but we also need to be in a much better interface with our emergency care system. And I know you already heard from Dr. Josh Stilley about work in that area. It's really important, and I'm so glad that he's partnering with us on that. Moving forward, gotta go. Okay. The other exciting thing from 2 summers ago, the National Jewish has a clinical research unit. I can bring patients in and we can do clinical research studies of surprising complexity. So we brought 18 people in to National Jewish and studied them over 6 hours, measuring saliva and blood cortisol and cortisone levels, both before their morning dose and after the dose. And what we learned from this was really twofold. One, there is wide variation between people in terms of how they absorb and metabolize their cortisone or cortisol, hydrocortisone dose. The second thing we learned is that saliva is a pretty good marker for plasma cortisol with a correlation value of 80% or 0.8. And so that gives us another tool. And I would say that this is the start of looking for a biomarker. Hopefully we'll have more and better work in the future. But again, it's each one of these projects gives us a little bit more of a handle on what to do and how to do research. This is another, I think, really important project that we're working on. We have a manuscript just about ready to come out. It nearly finished. And this evolved from the EMS work that I think Dr. Stilley has shared with you, and a partnership with Selma Witchell at the University of Pittsburgh, and a small group of us who kind of sat down and said, you know, we don't have a good definition of adrenal crisis to tell our emergency colleagues what is an adrenal crisis. And the hard, cold truth that you know is that they don't know. They don't know what an adrenal crisis is. They don't know how serious it is, how deadly it can be, and they don't know they need to treat it quickly. And so the purpose of this was to talk to patients. Amazingly, we had a wonderful interaction with our patient advisory group and a group of people from the Adrenal Registry who worked with us to clarify what happens in various stages of an adrenal crisis. And one of the most compelling aspects of this that has stopped colleague endocrinologists in their path is to read the comments from 91 people who participated in this, telling them about their experience. It has mattered a lot to those endocrinologists to hear the patient voices. And from that, I think we've crafted a valuable contribution, and we will go forward and use this to hopefully improve the EMS care and understanding of adrenal crisis. So final thing is this comparative effectiveness study with PCORI. This is important for our community. And basically, we're going to study 3 different treatment options: usual care, circadian adjusted oral cortisone, and subcutaneous hydrocortisone. I say we're going to study. We need to get the grant funded. It's going to take a lot of money and 5 years to get this study done. And I will need you to participate in it in some fashion. You don't necessarily have to be a research subject doing the different things, although we will desperately need and want people who are willing to do that. But we need you to be engaged in this whole process. There is nothing more important than an engaged community to move the research forward. And talk to me if you want to help. So where are we going to go? This is where I'm really excited. We're just getting started. There's a lot that needs to be learned. We don't know what works, and it's complicated. It's easy for us to get on phone calls and talk about our experiences and talk about what we want. But in order to answer the scientific questions, it's complicated, and we need to do it right in order to get change that's effective and really happens. We need to partner with all of the stakeholders that PCORI talks about, and we need to get beyond the PCORI grant. We need to get preliminary data for other grant submissions, because PCORI is a narrow grant. It's not going to answer all of what we need to know. And in order to get more federal grants, our community needs to be willing to put not only time into it, but money. The successful patient groups like cystic fibrosis, who've gotten basically cures for their disease, they got there because they pulled together as a community and invested in it. And that's what this community needs to do. Quickie on information. Please be suspicious and critical of information sources. They are not all equal. I would be happy to have more conversations, more webinars to talk about these kinds of issues, but be very careful about what you believe, and recognize that science evolves and changes. It's not rigid. And so it's normal and appropriate for one publication to say one thing and then another one to disagree. And the devil's in the details. So you got to look closely at the studies. Other considerations, I want you to know human disease is really messy and there aren't clear answers. So again, be patient. People have huge genetic variability. They have different life exposures and different physiology. People with the exact same diagnosis do not act the same. And if your neighbor has a different kind of adrenal insufficiency than you, that's their disease. Epidemiology, again, is our science, and it doesn't give us absolutes, it gives us probabilities, and it gives us information, but we have to continue to look at it critically and improve it with more research. And the final thought is real personal. I want to make sure you understand how much I share with you the frustrations of the disease. It is not an easy disease to manage for many of us, but it's really important to hang in there and not lose hope and continue to try to advance your own situation. You can make your life better. Obviously, if you're on this webinar, you've already connected with the patient community. There's huge value in that. The NADF, I know from being a board member and looking at it critically over the years, really tries hard to get the right information out and provide the support for people, whether they're members or are just cruising by. There's lots of good information there. My suggestions for you are to think deeply about what you want, where you're at. Do you want to actively manage your disease? Do you want to change things? What are your problems? And look at your symptoms. Try to understand what's going on. One of the things that often can be helpful is journaling, keeping a day by day, hour by hour record of your symptoms and your dosing. But the bottom line is take care of yourself. It's hard to find a good doctor sometimes. You may need to teach your doctor, so be patient. And the support that I've found, and I think many people find from talking to other people and having a support network, is incredibly important. So with that, thank you very much. And I'm happy to take questions if we have any time left.
Thank you, Liz, so much, Dr. Regan, I should say. Too familiar with you at this point. We do a lot of interest in your talk. You've got some big fans out there, I have to say. I think the biggest question that came up a couple times is, with the registry currently paused, how can those interested still get, their name in the queue so that when it reopens, they'll automatically get
Oh,
contacted? There's several people here who are interested, and then there's a few who must be somewhere outside the US because they're asking, is it only for US citizens?
okay. So, easy question. It is only for people who can adequately speak and write English. And that's a requirement of the Institutional Review Board that for a research study, people have to be able to read and understand the consent form to participate. So, if people are outside the US and want to provide information, we're only English language. To try to move to multiple languages, way more complexity than I can get into. But um, there there are a number of people in the registry already who are not in the US. Then the other issue, there are two ways that so there is an email address. It's adrenal, ADRENAL, at njhealth.org. That is an email address at National Jewish that comes into my email box, and you can send me an email there and say, I want to be on the list or whatever you want. That's a great way to communicate with me. It keeps it separate from my work email, which would get really, it just get too big for me to sort between the two. So I would prefer emails to that address. And I'd be happy to get back with people if they express an interest in the registry. Yeah, so.
So for those of us on the call today, or who watch this recording following, who are in the registry
Mhm.
but have not sent their medical records, guilty.
I know.
How, because how do you even go about doing that? How do you suggest we do that? And then for others, maybe who aren't in it yet, but they're planning on it, like to proactively start collecting that information.
Yeah. Okay. So I have a couple of volunteer students who work with me, and we periodically try to track down people who haven't sent records, and we are willing to help you. So Aiden is my main man who's been Aiden Krein, and he has been tracking people down. You may have gotten emails from him. But basically, at this point, when we contact you, there is a link in the contact that says you can upload your medical records here. So you need to get something from your chart. And as time goes on, most of us have these various kinds of my chart structures, and that allows you to download stuff from there. The minimum that we need is a doctor office note that includes a problem list. And on that problem list is the term adrenal insufficiency or Addison's disease or CAH or some kind of a physician diagnosis. That's criteria one. And then any evidence that you are being prescribed chronic use of hydrocortisone, prednisone, dexamethasone, anything that's a chronic use of the appropriate replacement hormone. Those are the two things that I need to be able to say, yep, this person meets our diagnostic criteria. So if you have problems doing that, email the adrenal at NJC at NJ Health, and we can help you with it. We can get back to you. But if you've gotten an email in the past, there may be a link. And if not, get back in touch with us.
Wonderful. So there are a few other questions here. Is the registry just for primary AI, or is it for all types?
Absolutely not. It's everybody who carries the diagnosis of adrenal insufficiency. And it may be uncomfortable for people, but that includes people who are on high dose steroids that have a secondary adrenal insufficiency. Sometimes they aren't welcomed in the community, which is kind of too bad because they got the same problem. Um, and they've got risks of dying from adrenal crisis. But in order to understand the disease properly, there's too many overlaps between different subtypes to limit to any one subtype. And I think at the beginning I mentioned, or maybe I didn't, but you can have primary adrenal insufficiency from an autoimmune mechanism. That's a slow onset disease. It can take 10 years to evolve. And at the point where you actually meet diagnostic criteria, you may still be secreting some, but inadequate cortisol. On the other hand, another primary adrenal insufficiency diagnosis could be somebody who had their adrenals removed for cancer. They got nothing. Those two people are totally different.
Very different.
Yep. We need to know both.
Yes. One last question, and then I think we're going to have to take the rest offline. But can someone under 18 be in the registry?
Yes, but it's a separate registry. There's a branch point when you click on the link and it asks whether you're under 18 or over 18. So we have a pediatric registry. It needs to have a parent involvement depending on the age of the child. This is specified by the institutional review boards to protect the children and make sure that the consent is done properly because children have a right to have privacy for their information. So yes, absolutely. Different questionnaires, different problems for children that we're going to be tracking, but we do want to know about them. And for the comparative effectiveness study, we do intend to study children down to age 13. So children are very important in this disease.
Yeah, for sure. I lied. One more question. Any update on when you think you'll be able to reopen the registry?
I have a call on Monday with the relevant parties. I'd love to say it will be within the next few weeks. I do think it'll be in the next month, but yeah, we have to work out some details.
Okay, great. And
We'll announce it through the NADF.
yes, NADF, look for our emails, social media posts on Facebook and Instagram, as well as LinkedIn. And I think we're on all of them, to tell you the truth. And we will follow up to the conference, and we'll include that registry email. There's a lot of people who are like, oh no, I missed it. Don't worry, we'll get that out to you. I do want to encourage our audience today because there's just been so much interest, and compliments to you, Dr. Liz, for doing this, and thanks and gratitude that the NADF is able to fund the research, but we're at a limited capacity because we're trying to do so much with so little. And if you do join the next closing remarks session, you'll probably hear me say something similar, but please donate as much as you can. We collect donations, and you can designate them for the MyAI registry if you want. That's fine. But please donate. This is really important research. Nobody else is doing it. There are a couple other questions in here about what about research on, seeing low cortisol in long COVID patients, and what about studying SAI, right? We can't, you've seen Liz has been working on this for years and years, and we can't further this along without your participation, number one, as she spoke of, but also your donations. And they go to good work, I promise you. So thank you so much, Dr. Regan, and we will get the questions that did not get answered live today over to you, and we'll get them back to our members. So please join us for some final remarks from myself and Kalina. We do have to exit this session and go back into go back to the lobby and join, but I hope to see you there in just a few minutes.